Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back to the show. Today, I am beyond excited to bring you a conversation with one of the most influential voices in nurse anesthesia education, Dr. Sass Elisha, or just Sass as he emphasizes to both his students and colleagues. Sass is the assistant program director at Kaiser Permanente School of Anesthesia, and chances are, if you've cracked open a textbook in your program, you've seen his name. He's the co-author of Nurse Anesthesia, Case Studies in Nurse Anesthesia, Critical Events in Anesthesia, and Current Anesthesia Practice. He's also the co-founder of the Nurse Anesthesia Educational Platform, found at www.thenurseanesthesia.com. He is nationally recognized as an expert in CRNA education and mentorship. In this episode, we dive into the pharmacology of the autonomic nervous system. Think adrenergic and cholinergic receptors, clinical relevance, drug decision-making, and how it all comes together in the OR. So grab your coffee, pull out your notes. Let's jump into autonomic pharmacology with Sass. I'm going to start off like I start off every podcast, and I just want you to tell us, the listeners, the students, how you ended up in CRNA education.
Good question. Well, I had just always been teaching. While I was in nursing school, I was teaching. I got done with nursing school. I was teaching. I did ECLS classes, BLS classes. And I just always knew that when I graduated from anesthesia school that I really wanted to teach. So I started doing some guest lectures here. And then you may know the name John Nagelhout. Nagelhout hired me, and I'm still not sure exactly why. But I remember him. I was sitting in his office, and I was contemplating going back and getting a doctoral degree. This was a really long time ago. And I remember him saying to me, "So what do you want to do when you grow up?" And I thought, I'm an adult. I'm in my early 30s. So I am grown up. And he said, "Well, consider going back and getting a doctoral degree in education if you want to be an educator for your career." And I'm like, that's really what I want to do. So that's kind of, yeah, one of my favorite educational quotes. A teacher affects eternity. He or she never really knows where their influence comes.
So can you give us like a high-level refresher on the autonomic nervous system, like the key components, and what we should keep in mind as anesthesia providers?
Yeah, sure. It's one of my favorite things to talk about because for all of your learners, you guys are going to be watching a monitor during someone is having general anesthesia. And you can't talk to them or ask them how they're feeling. And what you're going to do is make very complex decisions, hemodynamic decisions about what you're going to give or not give, depending on what the sympathetic and parasympathetic are doing. So if you can predict what the autonomic nervous system is going to do, you can be proactive in anesthetic as compared to being reactive in changing people's vital signs. So really quickly, to give you a high overview of the central nervous system, peripheral nervous system. So central nervous system is the brain, and everything else is peripheral to the central nervous system. Peripheral nervous system is comprised of two things: a somatic nervous system, which links the brain to the spinal cord and skeletal muscle. So this is under voluntary control. Of course, you can control moving your arm. But the second part of the peripheral nervous system is the autonomic nervous system. And that controls body functions, of course, like your heart rate, your blood pressure, your respiratory rate. And it's, for the most part, involuntary. The only thing related to the autonomic nervous system you can consciously change is your minute ventilation. You can decide to hold your breath, or you can decide to breathe faster. But that's really all we get. It's divided in, when we talk about the ANS, divided into two physiologic response. This is what we're going to be talking about. Sympathetic versus parasympathetic. So the first part, you already know, the sympathetic nervous system, your flight. I always say this to my students: when you can't remember what the body is going to do during fight or flight, think about running from a tiger. Think about what your body is going to do under extreme stress. And remember, when people come to surgery and have anesthesia, that is extreme physiologic stress. So there is a massive release of catecholamines. The three that we're going to be talking about, we're really going to focus on norepinephrine. That is a major catecholamine of the sympathetic nervous system. We also have epinephrine. We have incredible, powerfully physiologic responses that allow you to respond and protect yourself if you were running from that tiger. So just a couple of things for you in terms of mental acuity. This is not the time to reason or do a math problem. This is the time to run. So when you think about an emergency in the operating room, when we get freaked out, our brains say to run. However, in the operating room, you have to learn how to control your brain during an emergency and really focus, which is why it's difficult. All right, a little bit about the eyes. If you're running from a tiger, you need all of the light in your brain, and you need your lens to be able to accommodate so you can rapidly focus on objects that are close and that are far. Pupillar dilation and the ability to accommodate. So let's talk about the cardiovascular system. And again, you're running from a tiger. So of course, your muscles are going to need oxygen and substrate in order to make cellular energy. What is your heart going to do? So think about these things together always, because it's all or none. Heart rate is going to be increased. In addition, contractility will be increased, and also the rate of cardiac conduction. That is a sympathetic nervous system response to the heart. Think about the vasculature. What's going to happen to your blood pressure? Of course, it's going to be increased as you're trying to perfuse all the muscles. So when I know it's a silly analogy related to the tiger, but think about this as your patient in the operating room, as their vital signs change. So for instance, they become tachycardic and hypertensive in pre-op. Why is that? Of course, they're nervous, right? They become hypertensive and tachycardic after you intubate them. Why is that? Even though you've given them lots of drugs, their sympathetic nervous system is still reacting to you intubating them. So always put together the heart rate and blood pressure always in tandem and make sure they're accurate. But then think about what is happening to the patient's physiology, whether it's tachycardia and hypertension, tachycardia and hypotension. The diagnosis is different. I think we'll go over that a little bit later. Or lastly, bradycardia. I'm going to continue on. So we're going to talk a little bit about beta agonism and beta 2 agonists. Beta 2 receptors for us are really in the respiratory system. If you're running from a tiger, what do you need? You need bronchodilation. So your norepinephrine and epinephrine are going to stimulate beta 2 receptors, and you're going to have bronchodilation to get all the oxygen that you need into your blood. Minute ventilation is going to increase to get more oxygen in and your CO2 out. Think about your liver. What is your liver going to be doing? It's going to be doing everything it can to increase blood glucose. So increase gluconeogenesis and glucogenolysis. And then the pancreas is not going to secrete insulin because it's not the time to store glucose as fat. It's the time to use the glucose for energy. This is really interesting, the hepatic and the pancreatic effects related to the sympathetic nervous system. When you go to see your patient who's diabetic, especially preoperatively, and even if they have well-controlled blood sugar, despite being NPO, many times their sugars are going to be high and they're going to go, oh my goodness, that blood sugar is too high. Well, it's the stress response that's causing that. All right. So if there's a yin, which is the sympathetic nervous system, there's a balance or a yang, and that's the parasympathetic nervous system. It's called the rest and digest system. And so related to just the heart, it does all of the opposite. So you can think about an analogy here is someone sleeping, parasympathetic nervous system predominance. So if you can think about a balance, a teeter-totter, in the middle of the teeter-totter. And then on each side, we have sympathetic and parasympathetic. No matter what is happening to our bodies are either going to swing towards sympathetic or swing toward parasympathetic. SNS predominance is running from a tiger. PNS predominance is sleeping. We'll talk a little bit more about the parasympathetic nervous system as we continue. All right, Chloe, I got some, this is Chloe going back to school, so I got a couple of examples. So I want you to tell me about what's going on. So you do an induction, meaning you put the patient to sleep and you intubate them. The priority is to confirm breath sounds, which you do, and the tube is in the right place. The first blood pressure and heart rate after induction increases to the blood pressure 170/94, heart rate of 110. What would you call this? How would you diagnose this? And what would you do?
So I think, like you said, it's looking at the entire clinical picture of what's going on. So what did we just do? We just induced and intubated. So again, direct laryngoscopy is one of the most stimulating things to the sympathetic nervous system. With the pairing of the heart rate and the blood pressure being elevated, that puts on my front shelf diagnosis that the patient is probably light, that I need to deepen the anesthetic at that point.
That's right. Good. So the balance has swung toward the sympathetic nervous system side. And I really love what you said about what did I just do? So that is an important thing as you move through your anesthesia career, cause and effect. It won't always tell you what is happening and why, but a lot of times it will help to guide. Yeah, that's probably what this is. All right, here's another one. And I'll just kind of talk through this. We just talked about induction. Well, we got to wake the patient up. That's immersions. So when we're going through the immersion stage, we have to decrease the anesthetic depth as the surgeon starts to finish. So what do you think is going to happen as you start to decrease the anesthetic depth?
Well, as we start to decrease the anesthetic depth, like you said, we're getting towards the point of waking the patient up so that sympathetic, what did you say, the pendulum is swinging towards that sympathetic nervous system yet again. You would have increased blood pressure, increased heart rate.
Yeah, blood pressure and heart rate increases, but most times as you start to decrease the anesthetic depth, the sympathetic nervous system starts to come back slowly, of course, depending on what you've given and who is your patient. Watch for real subtle increases in heart rate at first, real subtle increases in blood pressure. And then all of a sudden, as you're decreasing your anesthetic agent, probably the inhalation agent, all of a sudden, the patient who is still anesthetized, they take their first breath. And then it continues up, swinging toward the sympathetic nervous system. Remember, your job in life while you're providing general anesthesia is to put enough drug into someone's brain to inhibit the sympathetic nervous system. Of course, you're also inhibiting unconsciousness, but really that's what you're doing. When you turn off the agents, you're going to see the sympathetic nervous system swing back. All right, let's do a couple more examples because examples are good. Because we're going to talk more about receptors in a little bit. All right. So after induction, the patient's blood pressure decreases from 80/40 and the heart rate is 110, which is exactly the heart rate that we gave you above. But this time, what has happened? Why has the blood pressure fallen? In the last example, the blood pressure went up. So Chloe, talk us through this.
So again, that heart rate is the same, but the blood pressure is low. So because the medications that we give on induction cause vasodilation, you're going to have a compensatory, or the body's going to try to compensate by increasing that heart rate. Again, same heart rate 110, blood pressure 80/40, very different intervention afterwards. So this patient obviously isn't in the same SNS state as the last patient with the hypertension and tachycardia. So this is when we would look towards a vasopressor.
Because when you see a heart rate, please get a blood pressure. In the first example, the heart rate was high, 110, the blood pressure was high. Cause and effect, intubation, and we can say the patient was light. That's what we say in anesthesia, meaning that their brain is light. We need to give more anesthesia in order to depress their brain. In this example that you just talked about, heart rate is the same, but the heart rate is increased not because of sympathetic response from Intubation caused by baroreceptor response from the blood pressure being so low. It's compensatory. We call this, meaning we got a lot of anesthesia in their brain and inhibited their sympathetic nervous system to such a degree that now their blood pressure is 80/40. You said consider a vasopressor, and that's right. We're going to talk about how you make that decision, but let's start slow and go big, right? So we can decrease our anesthetic depth. We can give IV fluid, and then we're going to talk all about vasopressors coming up, because vasopressors have a cost associated with giving them. All right. And then I think the last one is, let's talk briefly about vagal reflexes during surgical procedures caused by the surgery. So one example is during laparoscopic surgery, where the surgeon is going to create a pneumoperitoneum. That's a lot of CO2 gas in the belly that's going to dramatically increase intra-abdominal pressure. As it does this, it can initiate something called the celiac reflex. Celiac ganglia become stimulated. And think about normal digestion, right? If you got a big belly full of food, what does your body want to do? Does it want to run from a tiger, or does it want to chill out and digest? Well, of course, that's what it does. So what do you do as the celiac reflex makes the heart rate is a, again, parasympathetic nervous system response, makes the heart rate fall dramatically sometimes? What are you going to do? Chloe, how do you make that decision about telling the surgeon to stop and exfoliate, or considering giving an anticholinergic?
Personally, for me, I mean, I've had situations where the patient went asystole with insufflation. So this is not any time. I am up at the drape during insufflation every time, because once you see it go bad, you're always standing during that time. So it depends on how quickly it falls and how low it falls for me. With my experience, exfoliating tends to fix the problem pretty instantaneously. I will communicate with a surgeon prior to insufflation. Let's say the patient's heart rate's baseline 52. I'll say, hey, I know you guys are insufflating soon. I will let you know if the heart rate, but I will say, I will let you know if you start to insufflate. And honestly, the surgeons most of the time will say, I'm going to insufflate slowly. How about that? So they know a little bit more, they go a little bit slower. On insufflation, if the heart rate drops to 30, exfoliate, I'd give some anticholinergic at that point.
Most of our patients do not have an arterial line in. So, getting a blood pressure to make sure what is the patient able to generate an adequate blood pressure with that heart rate. Here's another one, and Chloe, I know you look at it, is all of a sudden, if you see a dramatic decrease in end-tidal CO2, even if the blood pressure, the cuff is cycling, you gotta believe that the blood pressure is really low as pulmonary blood flow is decreased. So that's another way that we can actually look at this and go, oh, it's really low. Like Chloe said, if it's hemodynamically compromising or significantly low in terms of the heart rate, the treatment is for the surgeon to exfoliate and then to start again. We can give anticholinergics. We'll talk all about what that is. Interesting, Chloe, I've had asystole too, not me personally. The patient developed asystole. I'm fairly sure I developed tachycardia. I remember that very vividly. However, the first time you see it, and you won't actually, I was like, no, that didn't just happen. I'm like, yeah, it just happened. That's why we train for the things and talk about the things that we talk about, because in an emergency, when we don't have time, we need to have a treatment strategy exactly as to what to do. All right, well, let's talk about receptors real quickly, and then we'll talk about and physiologic response, and then we'll talk about drugs. So adrenergic drugs are targeting adrenergic drugs, sympathetic nervous system, and they're targeting alpha and beta receptors. So we have alpha and beta receptors in lots of different places in our body. But in anesthesia, we're really concerned about the alpha receptors on the vasculature, because we know all of our anesthetics decrease the blood pressure. We're concerned about beta 1 receptors, which are primarily only located in the heart. And we are concerned also about beta 2 receptors, because those are located all over the place, also the vasculature, but beta 2 receptors specifically in the lungs. because if someone has a bronchospasm, we're going to need to be able to treat that. We have agonists. So if you're giving an agonist, a stimulant, you're going to mimic the sympathetic nervous system. So an adrenergic agonist. So I'm going to go over this with you because the words are really hard and people use them interchangeably. An adrenergic agonist is going to also be called a sympathomimetic. So mimicking the sympathetic nervous system, or as I've been talking about it, you can think about sympathetic nervous system predominance or swinging that balance toward the sympathetic nervous system. I mentioned earlier, when someone becomes hypotensive, we're going to give, when we work down our diagnoses and treatment, at some point, we're going to give a vasopressor. What I want people to know, and I don't think people think about this all the time, is, and anesthesia, for the most part, initially, we're giving vasopressors as push doses, which again is very unique to anesthesia. Vasopressors have a cost. Please remember that as we're going to talk more about them. All vasopressors are going to increase myocardial oxygen consumption. So for all of you healthy listeners out there with healthy hearts, not a problem. We can bump your heart rate up all day long. You can tolerate that. But for some of our older, sicker patients, please realize always grabbing for a vasopressor and always giving it and then giving more and more, it has a cost. But sometimes you have to give a vasopressor because you probably are aware of the concept of either cerebral or coronary artery autoregulation below those, those low values. And again, depending on who your patient, where the autoregulatory curve is shifted to the right, and those patients live at a higher pressure in order to perfuse their heart and their brain, which is, those are the two organs we care about during an anesthetic. We're always going to have to be thinking about what is the best treatment for them. So typically, someone becomes hypotensive. We decide we're going to treat it. I'll talk to you a little bit about how I make a decision, but the typical treatment for hypotension involves giving IV fluid, decreasing anesthetic depth, and then giving a vasopressor. So in a stepwise fashion, mild to more significant. You're also going to be looking at what's going on in the surgical field. Did the surgeon put a hole in something really big and the patient's bleeding? So there's a lot going on in terms of, I always say to my students, and I guess everybody is my students, you're like a detective in the operating room. When you see the heart rate going higher, the blood pressure going higher, yeah, it's probably light anesthesia or surgical stimulation. But I always tell my students, be a detective. What else could it be? Well, it's the initial stages of bleeding. So there's a lot of stuff.
You mentioned the cardiovascular effects already and the sympathomimetic. So let's kind of talk about the differences in the adrenergic and cholinergic drugs in terms of blood pressure, heart rate, cardiac output, just the cardiovascular effects.
All right. So let's start on the vasculature because we always are dealing with the vasculature and then dealing with the heart. And remember, almost every drug that you're going to give in anesthesia is going to have a direct or indirect effect on the heart and also the vasculature. So alpha-1 receptors. So let's just go over the receptor subtypes, both sympathetic and then also parasympathetic. So alpha-1 receptors for us cause vasoconstriction. Remember, the majority of your systemic vascular resistance comes from arteries, and therefore an adrenergic effect, an alpha-1 adrenergic effect or stimulation is going to cause vasoconstriction, and that's going to help raise the blood pressure. The cost, it'll increase myocardial oxygen consumption by increasing afterload. Remember, if we're causing increased vasoconstriction or increased vascular resistance, the left ventricle has to push harder in order to get blood out, right? And maintain stroke volume. Next receptors, beta-1 receptors, increased heart rate. So beta-1 receptors, for the most part, only reside in the heart. And again, I'm going to say this again, putting these all together. It's the beta-1 effect. If you were running from a tiger, it's going to increase heart rate, contractility, and cardiac output. So, and rate of cardiac conduction. Why am I saying this to you? Why do I say this over and over again? Here's the reason why. When you're going to come along and decide a patient needs a beta blocker, many times anesthesia people go, oh, his heart rate's high. let's just give them a beta blocker. However, you should always be thinking about what is the patient's preoperative contractility, what is the state of their heart prior to giving them beta blocker. Remember, you're already depressing their heart when you're giving anesthetic medications. So that's why I keep saying that to you over and over. All right, so we've gone alpha 1, beta 1. I'm going to mention beta 2 again. For the most part, for us, we're talking about the lungs. When we give a beta 2 agonist, we cause bronchodilation. So patients can have bronchospasm, and that's an emergency, especially if they're severe in the operating room. And the way to treat that is to give an adrenergic drug. We'll talk about some of them, and that is to cause beta 2 agonism or stimulation, which is going to cause bronchodilation. All right, that's enough about that sympathetic nervous system. It gets all the glory. It does because it's cool. But let's talk about the other side of the balance, which is the parasympathetic nervous system. So the major, as we said with the sympathetic, the major neurotransmitter is norepinephrine. However, with the parasympathetic nervous system, the major neurotransmitter is acetylcholine. So you're going to, again, the words are hard. So let's go over this. When you say cholinergic response, a cholinergic response is via acetylcholine. So cholinergic response will also cause parasympathetic nervous system predominance. And then here's a fancy pharmacology word that no one uses, but you can sound smart, cholinomimetic. So all of these are going to swing the balance toward the parasympathetic nervous system. Now, we talked about adrenergic receptors. What are the receptors of the parasympathetic nervous system? They're muscarinic receptors, and there are muscarinic receptors all over the body. There are multiple subtypes, which really aren't that important because acetylcholine does not discriminate between different types of muscarinic receptors. But what you need to know is acetylcholine binding to muscarinic receptors will cause a parasympathetic nervous system response. What the sympathetic response is in the heart. Heart rate will slow, contractility will be decreased, rate of cardiac conduction will be decreased. And that's through muscarinic receptors that reside on the heart. So isn't it amazing how our bodies are designed? If you just look at the heart, there are beta 1 receptors that will increase sympathetic nervous system and muscarinic receptors that will decrease it. So we have a yin and yang, or a balancing. And depending on what is going on with our bodies, that response is so unbelievably rapid in order to allow our bodies to best compensate for what is going on in the world. So clinically, we're often balancing these systems. When blood pressure drops, it's usually from a decrease in vascular tone. It's usually from a decrease in contractility. It could be from a decrease in heart rate, but it's probably multifactorial. And remember, every anesthetic medication has a direct or indirect effect on the cardiovascular system. So let me describe these really fast because I think this is important. So a direct effect is the drug directly, and let's just talk about the heart because it's easy. The drug directly depresses the heart, for example. So examples of this are like propofol or inhalation agent. But for a narcotic, narcotics don't directly depress the heart. They have an indirect effect at inhibiting the cardiovascular system. By putting the brain to sleep and inhibiting the sympathetic nervous system, you are going to inhibit the cardiovascular system from doing what it's supposed to do and reacting to the SNS as it does. So that's the difference between a direct and indirect acting drug or effect on the cardiovascular system.
Yeah, I think it's super important it seems like simple terms, but when you get down to it, these simple terms help us understand how these very complex systems in pharmacology work all together. So that's great.
And here's the example. You have a patient with a sick heart or a really poor ejection fraction. You're going to try to give them less of the drug that is a direct myocardial depressant because they already have a problem with contractility. So all of this information that we're talking about, I always try everything that I teach. I always try to make it extremely practical and usable. Otherwise, it's really not worth anything. It just, you can just talk about it.
Yeah, it gets everything that we do in medicine, it feels like, is very theoretical. The phrase I'm going to use in my lectures with my students is like, why do we care? So why do we care about this? At the end of the day, why do we care? And talking about all these different drugs and vasopressors, if you want to touch on a few of them, is again why we care about these processes.
Yes, you're exactly right. All right. So let's talk about the most common push dose vasopressor that you'll give, and that is phenylephrine. Phenylephrine is a pure alpha 1 agonist. It does not have any beta effects. So I'm going to put this in terms of advantage and disadvantage. I hope that when you start your career and you decide to give a drug, when you're giving that drug, please think about, I'm giving the drug for this reason. That's the advantage. However, the disadvantage to me giving this drug is if the concern or the disadvantage outweighs the advantage, don't give the drug. It sounds really simple, but it kind of makes sense. So, advantage of phenylephrine: intense vasoconstriction, dramatically increases blood pressure really rapidly with small doses, microgram doses. Typical dose 50 to 100 micrograms as a bolus. There are significant decreases, such as increasing the afterload, and especially in our patients with a history of poor ejection fraction or a history of heart failure. And if you remember from your physiology, what is normal physiology in relation to extreme vasoconstriction? That's going to be sensed by the baroreceptors in the aorta and the carotid arteries. And what's going to happen? What's going to happen is you're going to have a slowing of the heart rate, because all of a sudden the body thinks the blood pressure is really high. And if you give small doses, the heart rate slows, but not dramatically. However, this is what I wanted to say about phenylephrine, and it's not common knowledge, and I really don't know why it is, because it's super important. They have found, when they have looked at cerebral oxygenation, that actually cerebral oxygenation decreases significantly when boluses of phenylephrine are given. And they believe this is caused by a decrease in stroke volume, and then most dramatic in people with a history of heart failure. So think about this, guys. Normal physiology, you have low blood pressure, in your periphery, you have vasoconstriction. But what is happening in your heart and your brain? Those arteries are dilating in order to bring more blood to them, to the heart and the brain. You come along and give a vasopressor. That vasopressor has a cost. It doesn't just constrict the arteries in the periphery, it constricts the normal physiologic compensatory response also in the heart and the brain, causing vasoconstriction. So it's one of those things that we've been doing forever and may change in the future. I'll mention norepi in a little bit as a push dose vasopressor. But again, what I want you to know is all vasopressors have a cost. Our second most favorite vasopressor is ephedrine. This is a synthetic drug. I like to think of it as softer and nicer epinephrine, so not as dramatic as effects. But it stimulates alpha 1 receptors, beta 1 receptors, and beta 2. So the advantages are it will increase the heart rate, and advantage if the heart rate is slow. Someone develops hypotension and has a slow heart rate. Maybe they're on a beta blocker. That's advantageous. Also, it's going to increase contractility. Secondly, in terms of vascular resistance, the alpha 1 effect will increase blood pressure. And then you also get the added beta 2 effect, a beta 2 agonism, which is bronchodilation. So get this, if you had a patient who was bradycardic, hypotensive, and having a bronchospasm all at one time, which would be very unique, but you never know, a good choice would be to give ephedrine. Epinephrine is the bigger drug below, same receptor stimulated, alpha 1 agonism, beta 1 agonism, and beta 2. We're going to use this drug in small doses. Now, in the ICU, of course, you're giving 1 milligram dose, big doses, because someone's in cardiac arrest. But with severe bronchospasm, with anaphylaxis, with a blood pressure that doesn't really respond to phenylephrine in higher doses or even ephedrine, we can start giving epinephrine in small doses. 10 to 100 micrograms. And real quickly, I want to go over, because this is a mistake that people make, how to dilute that. So, the gold box in the Pyxis or the crash carts, The gold box, the gold epinephrine box, it is a milligram, 1 milligram per 10 cc's. So 1 milligram is 1,000 micrograms. If you take a 10 cc syringe, pull out 1 cc of the gold box solution. In that 1 cc, you have 100 micrograms. If you then add 9 cc's of saline to that, each cc or milliliter is now 10 micrograms. So the dose, if someone hasn't coded for low blood pressure, for anaphylaxis, for bronchospasm, is anywhere from 10 to 100 micrograms. All right, finishing up on these, norepinephrine. So same receptors as epi. Norepi has more of an alpha-1 effect with normal doses as compared to epi, which is more beta effect. People are starting to use push-dose norepinephrine. So small doses, like 5 micrograms. It's said to be, phenylephrine is said to be about 10 times less potent, or norepi 10 times more potent. So 5 mics of norepi, same amount as 50 mics of phenylephrine. However, studies are showing that not only does this bring up the blood pressure, but there is better cerebral blood flow as compared to phenylephrine, better oxygenation of the brain, because it doesn't have the inhibitory effect on cardiac output or stroke volume, because it has that beta-1 effect. So I think sometime in your careers, you will probably see norepi being used commonly as a push-dose vasopressor. The last two before I'm going to stop talking and Chloe is going to do the blockers is dobutamine, which is primarily beta-1, used during cardiac surgery, people with heart failure, not used that often in a non-cardiac setting. And then one drug we do use a lot, which is albuterol, which is given by inhalation. And we always say it's a beta-2 agonist. We give it for people who have asthma, who have a bronchospasm. But then I wanted to do one last bit of information. Are all beta-1 drugs beta-specific? Are they all beta-1 specific? Are all beta agonists or even beta-2 specific drugs, do they only work on beta-2 receptors? And the answer is no. Even the most selective for a beta-1 or beta-2 still does have some spillover effect into the opposite. So for example, albuterol is going to cause bronchodilation. For any of you that have asthma, get enough albuterol in your lungs, and all of a sudden you get a little bit tachycardic. And that's because of the beta-1 effect, or the beta-1 spillover effect.
I will never forget the beta-1 effect of albuterol, because during the pandemic, I did get, and they gave me albuterol, and I was having almost panic attacks. I was like, either you're gonna have to prescribe me Xanax with this albuterol or give me something else, because this beta effect it's funny how some people are more sensitive than others, but I always remember that beta-1 effect because of that. The other thing I was gonna mention is with epi, and you mentioned the dilution of epi. I always dilute epi for pediatrics. And it's because when I trained as a new grad CRNA, we actually had like 5 mics of epi in every Pyxis. Because if anything happened to a pediatric patient, if we couldn't ventilate or the oxygen saturation was going down rapidly and we were trying to troubleshoot why, giving a little bit of Sux and giving a little bit of epi would either break a laryngospasm, if that was the problem, or break a bronchospasm, giving a little bit of that epi. So it's hitting 2 birds with 1 stone with 2 meds to ventilate as quickly as possible, because as we know, peds can go south quickly once they start to go.
Yeah, we're not giving epinephrine all the time. Well, it's one of those things that you look at it and you're like, in an emergency, you're like, oh my God, what do I do? So I like to break it down into very simple, and when you need it in an emergency, you're going to need it. So that is an excellent clinical correlation there.
So let's talk about beta blockers, like you had mentioned, the adrenergic receptor antagonists, or the blockers. So the 3 we commonly use in the operating room: labetalol, esmolol, metoprolol. Each of them has a different type of mechanism of action, if you will, on those receptors. So labetalol is kind of your 2-for-1. I like to think of it in my brain. It blocks both alpha and beta. So you're going to get the beta effect of the decreased heart rate, but it also works antagonistically on the alpha, which means it causes some vasodilation, which helps in two different ways for hypertension in the operating room. Esmolol, on the other hand, is a very short-acting beta-1 blocker. And so it's great for managing short-term tachycardia or attenuating that sympathetic nervous system with direct laryngoscopy. It is very short-acting, as opposed to, lastly, metoprolol. This is, again, primarily a beta-1 antagonist, so it doesn't have that vasodilation that labetalol has, but it does last longer. So you have to keep that in mind as to what's going on in the operating room and with your patient. Can this patient tolerate a lower heart rate for a longer period of time, or do I just need to get this heart rate down because we just did direct laryngoscopy and now their blood pressure is 210 over 110 and we need it to bring all of these things down quickly?
Add one thing that you said for a test question, board question on labetalol is when you talk about alpha to beta blockade, it is 7 to 1. 7 beta blockade to 1 alpha blockade. So when you're giving labetalol, you're giving it because you want to give a beta blocker. A weak side effect or an additional effect of labetalol is to cause vasodilation. That is 7 to 1 thing that's going to show up on a test or a board question, or someone's going to ask you that at some point. So tuck that into a brain cell.
I love that, because at the end of the day, we want to pass boards. Providers, but we have to pass boards to become a safe provider. Let's talk about the cholinergic agents. So the peripheral nervous system predominant agents. What should students understand about these anticholinergics like glycopyrrolate versus atropine in terms of the onset, target receptors, and its clinical use?
You said anticholinergic, anti-acetylcholine response, anti-parasympathetic nervous system. So when we talk about the anticholinergics, we're really talking about 3 drugs that we use in anesthesia. That is glycopyrrolate, atropine, and then also scopolamine. And scopolamine pretty much is used as a patch for those people that may have postoperative nausea and vomiting. So in clinical practice, all of these drugs have an anti-muscarinic effect. We've already said this, right? Acetylcholine binds to a muscarinic receptor. If you give a drug that has an anti-muscarinic receptor effect, acetylcholine cannot bind with that muscarinic receptor. If that is true and the parasympathetic nervous system is inhibited, what is going to swing? What is going to happen? The pendulum is going to swing toward the sympathetic nervous system. When you talk about giving atropine or glycopyrrolate or even IV scopolamine, you're going to increase someone's heart rate, contractility, and rate of cardiac conduction. All right, let's talk a little bit about these, and then I'll go back to cholinergic agents in a second. So some stuff you should know about glyco. And really, I don't know a whole lot of other people that use it other than anesthesia people. So if you want to sound smart, you can say quaternary ammonium compound. Yay. It doesn't cross the blood-brain barrier, but the clinical correlation here is that as it doesn't, and atropine and scopolamine do, when you get higher doses of atropine and scopolamine in the brain, people can get really weird. They can develop restlessness, hallucinations. It's called central anticholinergic syndrome. And you'll read about that in the future. It's the mad as a hatter, red as a beet, dry as a bone. So what has happened with atropine or scopolamine? It's gone into the brain. It has inhibited acetylcholine and how it works in the brain. And this is actually what happened. Clinical question, test question, board question. What do you do? What medicine could I give to counteract central anticholinergic syndrome? The answer is a drug called physostigmine. It is a cholinergic drug. And what it's going to do is it is going to increase acetylcholine in the brain. And as it does, the effects are going to go away. Okay, why do we more commonly use glyco? Because it doesn't increase the heart rate to the same degree that atropine does. We're really going to use atropine if we've really got someone's heart rate that really falls and keeps falling, as Chloe was talking about. Atropine does cross the blood-brain barrier. We're concerned, especially in our pediatric patients who are at risk for developing bradycardia, giving them multiple doses and having that anticholinergic syndrome. However, it works super fast and it is super effective. So think about glyco for planned reversal to offset bradycardia associated with the anticholinesterase agent. So let's go back to this. So I'm kind of done with anticholinergics, right? Inhibiting acetylcholine's effect by having an anti-muscarinic effect. What I haven't talked about is cholinergic agents, agents that increase the concentration of acetylcholine in the body. The drug that we give to do this that is not that commonly used anymore is neostigmine. Neostigmine is a drug that we can use to reverse neuromuscular blockade. The drug itself will increase the concentration of acetylcholine, and that's what we want at the neuromuscular junction. But it doesn't only increase acetylcholine at the neuromuscular junction, it does it everywhere. And what would happen if you had a tremendous amount of acetylcholine around the heart? Yep, patient would develop bradycardia. So when we are giving a drug like neostigmine, we're going to mix it with a drug like glycopyrrolate to offset any bradycardia that may occur.
Yeah, those muscarinic receptors aren't just in the neuromuscular junction, they're at the... And I always wonder if eventually mentioning neostigmine and glycopyrrolate as reversal agents will be like mentioning halothane, you know? I guess it's getting to that point where we use sugammadex so often that it may turn into that. So
I always say to students, I'm like, one day there's an anesthesia student that's going to come up to you and say, oh my goodness, you actually gave someone isoflurane? It doesn't matter how young you are, at some point, somebody is going to look at you like a dinosaur and it's like, oh my God, you gave that? I'm like, yeah, I gave that.
And that's the beauty of pharmacology, because it just keeps getting better and better. So what is your framework for choosing a vasoactive agent to treat intraoperative hypotension? So when do you reach for phenylephrine and when do you reach for ephedrine, for example?
Yeah. So the first thing that I always do in current times, it seems like people reach for vasopressors much more rapidly as compared to old people like me. We kind of waited a little bit longer before we would give a vasopressor. And I'm thinking that maybe one of the reasons these days is because of electronic charting, that people are jumping to vasopressors really quickly. The first thing I do is I always put the patient into one of three baskets. I put them in terms of the heart basket. Either they're a healthy person, like hopefully you and I, and our hearts and brains can manage a little bit of hypotension, mean arterial pressure below 60 for a little bit, as we give volume and decrease the anesthetic depth, or the surgeon stimulates something and the blood pressure comes up and I don't have to give a vasopressor. However, then I put people into a next bucket, and that is a person with, maybe they have obesity and type 2 diabetes, but they have decent exercise tolerance and, their blood pressure falls. Yeah, I still want to treat it, but I'm not going to wait as long if their blood pressure is soft before I treat that. But I am going to wait a little bit, as compared to the last bucket is the guy that's really sick, the guy that has a history of vascular disease or history of CVA or really bad stroke volume or history of an MI. That's the guy that I'm going to get a pressure. It shows low. I'm going to get another blood pressure immediately. And as it's cooking, I'm giving volume, decreasing the anesthetic depth, and picking up my vasopressor, because the moment that next blood pressure comes up, if it is indeed low, I'm treating it, because that's the person that is going to have some kind of cardiac or cerebral event intraoperatively. The second step is identifying the cause, which you talked about earlier. Is the cause due to vasodilation? Are they volume depleted? Is there a drop in cardiac output? So what do I think is going on? And then you ask the question, when I've decided, yes, I'm going to give them a vasopressor, how do I decide on which one, phenylephrine or ephedrine? And so when you remember about adrenergic receptors, it makes it very easy to make a decision. Remember, ephedrine is going to have an effect on the heart rate. It's going to have a beta-1 agonist effect. It's going to increase heart rate. So if someone's bradycardic to begin with, your vasopressor of choice should be ephedrine. However, what if someone is tachycardic and hypotensive, meaning their heart is compensating for their low blood pressure? Well, you can kind of do two things at once. Treat their blood pressure and bring their heart rate down slowly and a little bit. For those of you that are not, really don't have the experience yet, 50 to 100 micrograms of phenylephrine is going to bring most people's heart rate down anywhere from 5 to 15 beats per minute. Again, it's a small dose. But again, knowing how the drug works is going to allow you to achieve what you want.
Yeah, at the end of the day, it all comes down to the clinical context, the patient's history, hemodynamic monitoring, putting all of those together before we make the decision on what to give based on the current clinical picture. What about hypertension during surgery? What agents do you prefer? How would you tailor your approach based on etiology or patient comorbidities?
Yeah. So again, trying to identify the cause. What just happened? Did the surgeon start? Are they tugging on something or cutting the attachments to an organ? Is the patient light in terms of what I'm giving them? Who is the patient? Is the patient 20 years old? 20-year-olds need a lot more anesthesia as compared to 80-year-olds. So again, who is your patient? And then lastly, what is their fluid volume status? But this time they're hypertensive. Please do realize something. Once you give medicine that is not decreasing the anesthetic depth and decreasing the anesthetic depth and also trying to determine the cause, once you give a drug like hydralazine, you're going to live with it. You're going to live with it for a while. So all of a sudden, you've given hydralazine, the pressure's come down, and now the surgeon has put an enormous hole in an artery. So again, that's why when we see hypertension, treat it in a stepwise fashion. What do? First thing, throw the anesthesia kitchen sink at it. Assume that the patient is light. Assume that it's possibly surgical stimulation. Deepen the anesthetic. Inhibit the sympathetic nervous system. You can do this with inhalation agents, propofol, opioids, dexmedetomidine, whatever you want, or a combination. However, if a patient remains hypertensive, right, after you've thrown the anesthesia kitchen sink at it, depending on what's going on. So is the heart rate not high? They're not tachycardic, but they're hypertensive? A drug that you could use is giving hydralazine. Hydralazine is going to cause vasodilation. As it does, it's going to have the opposite effect of phenylephrine. It'll actually increase the heart rate in that baroreceptor response in the opposite way. Is the patient tachycardic and hypertensive? Well, maybe what I'd like to fix first, assuming that I'm giving a lot or enough anesthesia, is fix the tachycardia, because that factor is the worst for myocardial oxygen supply and demand. So we can give some, depending on who the patient is, esmolol or labetalol, see what happens, see if the blood pressure comes down, not only with the beta blocker, but also with giving more anesthesia. So I always say this, we always win. Whether it's hypotension or hypertension, we will always win because we have enough drug to win whatever we need to do in order to get the blood pressure up or the blood pressure down. And I'll say one last thing about this hypertension. Certainly you have to be more careful in people with coronary artery disease. They don't do well with significant hypertension because it's going to put strain on their heart, and it's all about oxygenation, especially if you have that particular patient. But realize this, at some point, you're going to have to wake that patient up. That patient that was incredibly hypertensive, that you had to treat them with a drug like hydralazine intraoperatively. As you wake them up now, if you didn't give them hydralazine or some other kind of vasodilator, and you turn off the anesthetic agent and the sympathetic nervous system comes back, instead of their blood pressure increasing to 140/80, it now increases to 190/100. So that is an advantage to giving an intraop dilator if a patient needs it. So again, it's always, who is my patient? What am I trying to achieve? And then titrating.
And I love how you mentioned wake up, because that's what we've mentioned multiple times throughout this discussion is we are being proactive, not reactive. So even in the middle of the case or after intubation, you're thinking this patient's heart rate and blood pressure, didn't really come down. They're at a mac of gas. That's when my ears start perking up, like, okay, well, maybe there's something else physiologically going on here that I'll have to treat intraoperatively so that I can anticipate what the wake up's going to look like and what the blood pressure will look like upon wake up. And then second, I have an anecdote from the OR where you mentioned being an investigator, right? We are investigators. So I had a patient that was hypertensive, incredibly hypertensive. So I started deepening the anesthetic, but what did we just do? We had just positioned Trendelenburg as well, right? So you start to think about the increase of cardiac output from Trendelenburg positioning, but it still something wasn't adding up. And in the OR, I always tell students, like, if you have a gut feeling, go with the gut feeling, continue to investigate the gut feeling because there's probably is something that's not quite right. Long story short, the strap that was holding the patient to the operating room table was now directly over the blood pressure cuff. So now we're in this Trendelenburg position, the pressure from that. So we ended up loosening the strap, retaking the blood pressure, and it was like 130s over 80s or whatever. So it was that investigative piece that we have to consider. So that's an anecdote from me with a hypertensive patient in the OR. Thank God I hadn't given hydralazine.
Yeah. Maybe at some point in the future, I can come back and we can do a podcast on differential diagnosis. That's one of the things that I'm working on in terms of trying to get the word out and having a process to make a decision as to what you believe is going on. So, I love the story. That's fantastic.
But since I just shared that clinical story, let's talk about some practical tips for integrating this autonomic pharmacology that seems a bit overwhelming, I'm sure, to listeners and students. Transfer that into the day-to-day intraoperative care. What are some practical tips or clinical pearls you have?
Yeah. So don't memorize drugs in isolation. I think about them in terms of their context. What are the drugs going to do? And if you know what they're going to do, you know what the receptor targets are. So a drug that's an alpha drug, that's phenylephrine, or a beta blocker like esmolol, right? It ends in olol. A muscarinic antagonist or an anticholinergic like glycopyrrolate. And just for knowledge, no one says muscarinic antagonist, but that is what it is. So once you understand the physiologic effect and the receptor that it works on, it's going to be easy. And for those of you that haven't been in the operating room, as soon as you do and start giving these drugs, it will become second nature to you. Chloe, I love one thing you said earlier about if you have a hunch, follow your hunch. Again, you guys are ICU nurses, so you've given these drugs, maybe not like this, but you've given almost all of them. And that is that sixth sense that we all get from being ICU nurses for years and years and years. Chloe's right. Make sure you keep that, and make sure when you think this picture doesn't look right, investigate to see why it doesn't look right. In terms of treating things, we have written down here using algorithms to see when the blood pressure is low or the heart rate is high. So you can use cheat sheets, certainly working with your classmates, talking in groups. But me and some of the guys I work with, we love checklists. We started a new business. It's called the Nurse Anesthesia. We have a website, www.thenurseanesthesia.com, and we have a whole bunch of free checklists, including the treatment of hyper and hypotension. Go and get them for free and distribute them to the world. We would love that.
I've used the checklist and your little crisis Bible. I call it the crisis Bible. Those things are so good to have. I always tell students there is no shame in pulling out a checklist ever, period. No one is expected to have every single intervention, dose, timing memorized, and they are such great things to have for patients. So any final pearls or memory tricks for mastering this topic from a pharmacologic or clinical perspective?
Yeah, so maybe pairing drugs. So pairing drugs like phenylephrine and ephedrine. Those are going to be used exclusively to treat hypotension. We're going to consider phenylephrine if the heart rate is high, ephedrine if the heart rate is low, and then always, again, titrating and considering who is our patient. So if I have someone with a higher heart rate, but I don't want to give them a whole lot of ephedrine because they have an ejection fraction of 30%, we may start them on a drip. So again, always who is your patient. Next, thinking about the blockers together, the most common beta blockers that we have in the cart. Okay. The good thing about esmolol, it's metabolized in minutes. Labetalol has a longer half-life and that mild vasodilatory effect. Glyco, we talked about, the anticholinergic can be used to inhibit secretions, can also be used to prevent bradycardia. I promise you will get this. And then one last thing here is, when you're thinking about treating blood pressure, is it heart rate? Is it blood pressure? Is it their volume depleted? Is it they're taking their beta blocker? Is it I'm giving too much SIVO? There's so much here. There's so much to think about. Think about this in segments, right? Think about alpha is squeeze, beta is pump, and the muscarinic effects are going to slow down the heart rate. I always tell my learners to think about the cardiovascular system as the tank. The tank is the intravascular volume. Next is the pump. The pump is the heart. And then last is the vascular resistance. Where is the problem? So is the patient developing ischemia, myocardial ischemia? The problem is the pump. Are they developing anaphylaxis? The problem is the pipe. Are they bleeding? The problem is the tank. So please do realize that most of our patients come to us with hypovolemic, taking a drug that is going to inhibit their cardiovascular system, and then you're going to come along, give them anesthesia. So you will live your life on the hypotensive side and be having to make all of these decisions. We've been talking for a long time and we're going to stop, but we haven't even talked about how in the world does norepinephrine cause an increase in heart rate, contractility, and rate of cardiac induction. Well, really briefly, you guys probably aware of first messenger, second messenger, if we're talking about a cardiomyocyte, third messenger, so we're talking about the heart. In the case I gave you, the first messenger would be the drug or the chemical, such as norepinephrine. The second messenger intraoperatively, when that G protein is stimulated, is cyclic AMP or cyclic GMP or others. And then what is the end result? In the heart, it is to increase calcium. And this makes perfect sense. You're going to learn about myocardial excitation contractile coupling. That is going to increase contractility. So a lot of this stuff in terms of physiology, there's always more to learn, but we've been talking long enough, so no more today.
Yeah, we'll have to bring you back for part 2. The last question, as we wrap this up, I ask every guest. So if you could give us just one piece of advice to an anesthesia learner in the throes of anesthesia school, what is one piece of advice or encouragement you would give?
So it's hard being a nurse anesthesia learner. I remember it. And what I would say to you is a couple things. First thing is trust the process. Being a nurse anesthetist and going through the training process is brutal. It has to be. You're going to be providing anesthesia, and we've all gone through it. So make sure that you try to stay positive. Make sure that you try to, one foot in front of the other. Try not to look at the end. Try to look at day by day, week by week, and month by month. And then probably the thing that I didn't do that I should have done is give yourself grace. If you're working really, really hard, but you're a new anesthesia student starting in the operating room, I know that everything that you want to try to accomplish is not going your way. I always said the vocal cords, I called them unicords when I was a student, especially starting because I couldn't find them. So it is a demoralizing process, but please don't ever give up and always remember that you got into anesthesia school and that you're a super smart person. And if you keep working hard, one day this will be over. And then last, no one has ever argued with me that life is better after anesthesia school. You can ask Chloe.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.